Without any further ado, it gives me great pleasure to introduce our first speaker for today, Professor Cathy Stinear. So Cathy is a Professor of Clinical Neuroscience and is also the Deputy Head at the Department of Medicine at the University of Auckland. So she's going to be giving a talk today on biomarkers and prediction tools for stroke research. Thank you very much, Cathy.
Great, thanks so much, Nigel, and thanks to the whole group for the invitation to speak today. I'll just get these slides running. Okay, so we're here to talk about biomarkers and prediction tools for stroke research. Just quickly, what we'll cover in the next 20 minutes is predicting recovery and outcomes after stroke. Why might that be a good idea? What makes a good biomarker, and how biomarkers can improve the design and efficiency of our clinical trials. Most of what I'm going to talk about today is relevant to the motor system. As I'm sure you're all aware, motor function is very commonly impaired by stroke, with around 3/4 of people experiencing at least some motor impairment. And motor recovery is absolutely critical for regaining independence in daily activities after a stroke, particularly for the upper limb. A study a little while ago now, quite a large study, looked at a huge range of factors to see what influenced the level of independence 6 months post-stroke. And these 3 factors were found to be the most important and independently important. So upper limb function, age, and stroke severity. We can't actually do much about people's age and stroke severity once the stroke's already happened, but we can certainly try to help rehabilitate their hands and arms to help them regain as much independence as possible. So a lot of what I'll talk about today is around upper limb recovery. Prediction is actually just hard. It's just a really difficult thing to do, particularly when you're basing it just on clinical impression or judgment. And that's because patients with really similar performance at the acute stage of stroke can have very, very different recoveries and outcomes. And I can illustrate that with some data we collected a while ago now. Each of these lines is a patient. There's 40 patients here, and they were evaluated within 2 weeks post-stroke, and again at 6, 12, and 26 weeks post-stroke. And they were evaluated using the Action Research Arm Test, which has a maximum score of 57. So most of us today would score a 57. And you can see that as a group, there's a generally positive trend. Most people improve at least somewhat over time. But there's a huge amount of variability in here as well. So if we take an example pair of patients that start off with moderate dysfunction, you can see that one person did quite well, and by 26 weeks post-stroke, they almost had a full score, whereas the other person who started in a similar place didn't really show that much recovery. Here's another quite interesting pair who started in exactly the same place with moderately to severely impaired function. One had a spectacular recovery and had a very good outcome, and the other had a much more modest recovery trajectory. And yet, if you looked at them clinically, they would appear to be the same within those first couple of weeks. The ones that are really challenging are the people that start in that bottom left-hand corner, who, 2 weeks after that stroke have very little movement in their hand and arm, and yet some go on to have quite good recoveries and reasonable outcomes, and others really don't improve at all. But the point is that you can't tell just by looking at them. Your baseline sort of clinical assessments don't actually tell you which of these 2 people has the potential to go on and make a good recovery and have a good outcome, and which one perhaps doesn't. And that's really problematic for patient selection in clinical trials that are started at this early stage. So how might biomarkers help this? Well, first we just need to make sure we know what a biomarker is. It's a defined measure derived from molecular, histologic, radiographic, or physiologic characteristics. It's an indicator of normal biology, pathology, or the response to exposure or an intervention. And it is quite distinct from clinical outcomes, and this catches a few people out. So clinical outcomes are how a person feels, functions, or survives. And these are the things that can be readily observed by looking at the person. Whereas biomarkers are things that need to be measured. They sort of get at things that we can't tell just by looking at the patient. There's a couple of different kinds of, there's plenty of different kinds of biomarkers. The 2 that I think are relevant here are prognostic and predictive biomarkers. Prognostic biomarkers are those that tell you something about the future in the context of the natural history of the disease process or the recovery process after stroke. So regardless of what sort of treatment the person experiences. Whereas a predictive biomarker is a biomarker that predicts whether or not someone will have a beneficial response to a specific treatment. So predictive biomarkers are useful for selecting patients for specific treatment approaches. The most important thing to get out of these biomarkers is that they are telling us something about the future. So a lot of studies find what they call biomarkers in cross-sectional studies, and that's fine, except they're cross-sectional. So they're not actually predictive or prognostic, because they're not telling us anything at all about what to expect for the future. They're only telling us about what's happening right now. After stroke, there are two main types of biomarker that have been investigated. There's neurophysiological ones, which are obviously most relevant to our discussion today, particularly TMS and EEG biomarkers. There are also several neuroimaging biomarkers that have been tested using varieties, different flavors of MRI. So what makes a good biomarker? Well, it's something that can be readily obtained early after stroke, because to be sort of useful in clinical practice, we need to be making predictions about the future at the beginning of the rehabilitation and recovery process so that we know what to expect for that person. There need to be clear cutoffs. So we need to be able to find measures that clearly distinguish between likely recovery and outcomes. And they do need to predict something useful. So complex multivariable regression models with lots of variables in them that predict something like your Fugl-Meyer score, I would argue that clinically that's not particularly useful. I don't know what a patient would do with information like we think your score will be 49 plus or minus 3. So predicting something useful and tangible for patients and clinical teams, I think, is a good thing for a biomarker to be able to do. So let's just turn our attention a little bit to TMS biomarkers. The easiest one, the most straightforward one, is just whether or not you can elicit a motor evoked potential in specific muscles of the paretic limb. So the presence or absence of a motor evoked potential simply tells us whether or not the descending motor pathways are functional or not early after stroke or at the time of testing. So presence or absence is the simplest type of TMS biomarker. Various authors have looked at other variables such as the threshold, rest threshold typically, the latency of the MEPs and their amplitude. But of these, simply MEP status, whether you can elicit a response or not, appears to be the most robust out of these particular types of measures. So MEP presence or absence, it won't surprise you to hear that MEP positive patients in whom an MEP can be elicited soon after stroke, have better motor recovery and outcomes than MEP negative patients. That makes sense. If the descending motor pathways are functional, you're going to be better off. What's interesting and important though is that people can be MEP positive even though at the time they have zero voluntary muscle activity. So they're unable to activate those descending motor pathways, but TMS can. And so we're able to elicit an MEP and have a more positive outlook for that patient, even though at that time they are profoundly weak. Most of the work looking at TMS biomarkers and MEP status in particular has been done in the upper limb. Much less is known about whether or not there are any useful TMS biomarkers for the lower limb in terms of predicting both strength and walking outcomes. But what we do know in the upper limb is that MEP status has high negative predictive value, which means if you are MEP negative, i.e. if you don't have a response to TMS soon after stroke, you are most likely going to have quite a poor recovery and outcome for that hand and arm. The positive predictive value though is more moderate, which means that most people who are MEP positive will go on to have a good recovery and outcome, but there are a handful who don't do that well. And we're currently doing some research to understand why that is the case. They have a functionally intact descending motor system, but they actually don't make such a good functional recovery for their hand and arm. And it might be that they're being held back by other impairments in sensation, vision, other disorders like apraxia that impacts their function, even though they do have an intact CST. So just switching gears slightly for a second to structural MRI biomarkers. Some key ones that have been investigated are the volume of the stroke lesion, the lesion load on the corticospinal tract, which is exactly what it sounds like. It's sort of depicted here in this study from Jeff Riley and company. And basically the proportion of the corticospinal tract that is directly overlapped by the stroke lesion can be measured as CST lesion load. And measures from diffusion-weighted imaging, such as the asymmetry of fractional anisotropy, again in those descending motor pathways, or in volumes of interest, such as at the posterior limb of the internal capsule. Those types of measures have also been shown to be quite useful predictors of subsequent motor recovery and outcome. Of these, several studies have now accumulated to show us that CST lesion load seems to be a useful and robust biomarker of motor recovery and outcome after stroke. Just looking a little bit more closely at that though, again, it won't surprise you to hear that people with less lesion load on the CST have better motor recovery and outcomes. And again, most of the work has been done for the upper limb rather than the lower limb and walking. But here's some data from Wayne Feng's group, which illustrates one of the limitations though. The x-axis is showing you corticospinal tract lesion load volume in cc's, and the y-axis is showing you the upper extremity Fugl-Meyer score at 3 months, and a good score, the best score that you could have, is 66. And you can see that there's this general relationship here, where the higher your lesion load, the worse your score is at 3 months. So that makes sense. People with the lowest lesion loads have better scores. People with the highest lesion loads have worse scores, but there's this kind of annoying zone in the middle where it could go either way. You could have a lesion load around 4 and sort of score anything on the Fugl-Meyer. So these relationships exist between lesion load and scores like the Fugl-Meyer at 3 months, but there's no clear cutoffs. The relationships exist for groups. So it's a little bit harder to use this kind of biomarker to make predictions for individual patients, particularly when their lesion load is falling into this middle sort of grey area. Coming back to MEP status and how it relates to lesion load, as I've said, MEP status reflects the function of the corticospinal tract. It does predict potential recovery, particularly of individuation of finger movement. That's really crucial. Patients who are MEP negative can recover some limited proximal movement around the shoulder and elbow, and occasionally can even recover some gross hand opening and closing, but MEP negative patients are just unable to recover fine finger control because that critical monosynaptic corticospinal tract has been irrevocably damaged. MRI biomarkers, like the ones I've just shown you, CST lesion load, actually add no value when patients are MEP positive. That's important. It means that if you can get a response to TMS, it actually doesn't matter what the tract looks like on the scan. If it works and responds to TMS, doesn't matter what it looks like. However, if the patient is MEP negative, then those MRO biomarkers are related to outcome. Then they start to contain some information. And I'll just show you how these sort of work together. These are some data of ours. Sorry, that's a little bit fuzzy. The x-axis is showing you CST lesion load, and the y-axis is again Fugl-Meyer score at 3 months post-stroke. The blue dots are people with MEPs, the orange are without. And you can see that in general, as I said, people who are MEP positive have better scores at 90 days than people who are MEP negative. They're sitting higher on the graph. And if we look at people with a low CST lesion load, most of the people with a low CST lesion load do well and have high Fugl-Meyer scores, unless they're MEP negative. And then they're going to be sitting much lower in their scores. And down the other end, most people with a high lesion load will do poorly and have low Fugl-Meyer scores unless they're MEP positive, and then they'll still have quite high scores, right? So that dotted line through the blue dots, there's not significantly different to 0, so there's no relationship between lesion load and Fugl-Meyer score for MEP positive patients. But the orange dotted line is different to 0, so that relationship only exists for MEP negative patients. The point is that biomarkers might only be useful in combination. So the MRI biomarker is only useful if you know MEP status, and MEP status trumps the MRI biomarker for making predictions for individual patients. So how might prediction improve our trial design and efficiency? Well, I'll put it to you that we do need to be testing our potential stroke treatments and rehabilitation approaches at the subacute stage of stroke, because that's our best opportunity to interact with the spontaneous recovery processes that are responsible for so much of the improvement we see. So we can really interact with those processes and hopefully boost them at the subacute stage. And the second reason is more pragmatic, which is that's when rehabilitation is delivered. That's when service delivery occurs. And so while we can learn interesting things by testing treatments with patients at the chronic stage, the reality is we don't have a service platform to deliver those treatments to those patients on any real scale. So we do need to be able to test treatments at the time we intend to use them, which is usually within those first initial weeks post-stroke. I'll put it to you that balancing treatment and control groups just on baseline characteristics is actually inadequate for the reasons I've shown you before. And as a little reminder, there's that graph again. You can have two patients that are perfectly matched on their baseline characteristics, but unbeknownst to you, one is destined to have a much, much better recovery and outcome than the other. Right? And you can only tell these people apart by using a biomarker, particularly something like MEP status. So you could, by chance, load up all of your treatment group with people with poor recovery potential, and your treatment might be quite effective, but you're going to miss seeing that because your groups are actually unbalanced for their potential to respond to the treatment you're testing. So you do need to balance your groups on their likely recovery and outcome, not just their baseline characteristics. By way of example, here's some data that we published a couple of years ago. We had a full sample of 207 patients, and you can see just a few of the data, just some of their characteristics here: their age, sex, NIHSS score, where low is good, high is bad, and their upper extremity Fugl-Meyer score at baseline. And then we just took out just the people who were MEP positive, right? So we had 177 of these, and you can see that as a group, they overlap pretty much. They've got a similar range for their NIHSS score and the same range for their Fugl-Meyer score at baseline. So statistically, these two groups are well matched on their baseline characteristics. What we wanted to know was what sample size would we need to detect a 7-point difference in the FM score between a hypothetical treatment and control group at 90 days, right? So knowing what we know about these patients. And we also wanted to know how long would it take relatively to recruit them if we were not selecting patients, so just looking at the full sample, or if we were selecting based on patients being MEP positive. What difference would that make to sample size and the time we'd need to recruit the sample? Here's what we found. I'll just walk you through this. There's a lot of information here. So first of all, when we looked at them again at 90 days, we had a sort of a similar looking average FM score at 90 days, but importantly, the standard deviation was quite a lot lower in the MEP positive group. So the selected patients have much lower standard deviation. Right, so we have less variance in the group. That's good because it makes it much easier to detect treatment effects when there's less noise in the sample. We then calculated the sample size needed to detect a hypothetical 7-point difference. And you can see that by selecting only the MEP positive patients, we need a sample size that's only about a quarter of the sample size that we'd need if we didn't use MEP status as a selector. That's huge. That's absolutely massive to be able to drop your sample size to only around 25%. That's a very efficient trial now. And then we calculated the relative time to recruit relative to the full sample. If we were using TMS and only selecting the MEP positive patients, it would take us about 1/3 of the time. So you could get an answer in 1/3 of the time with 1/4 of the patients. That's going to make your grant application look pretty competitive, because you're able to be very efficient in your use of time and resources. So we did this for a hypothetical 7-point difference in Fugl-Meyer score at 90 days. If you do the same thing for a 7-point difference in ARAT score, the Action Research Arm Test score, you see basically the same pattern. Much less variance, you only need 1/4 of the sample size, and you'll recruit them in about 1/3 of the time. So we think this shows or demonstrates, at least in principle, that using the MEP status biomarker to select your patients can make a real difference to the design and efficiency of your trials. So using MEP status to select participants matches groups for predicted recovery and outcomes, not just their baseline characteristics, decreases the variability in your subsequent primary endpoint. This increases your trial sensitivity. You're much more likely to be able to detect an effect of your novel intervention against that background improvement that everyone will probably be experiencing in those first weeks and months. And it reduces your sample size by around 75%, which is pretty great. That's all I have for you. Happy to take questions.
Fantastic. Thank you very much, Cathy. And I think that talk is just such a beautiful example of how something simple like the humble MEP can really have fantastic clinical utility. So it's yeah, really great body of work. If any of you have any questions, now's the time to please pop those into the Q&A Q&A box down the bottom there, and I can pass those on to Cathy. Just while we're waiting for people, I was just wondering, Cathy, whether you looked at any other, I guess, TMS markers, looking maybe at some of the intracortical circuits, or so SICI, ICF, those kind of measures, and whether they add anything at all just on top of the corticospinal tract activation markers.
The short answer is we've had a bit of a look at some of those things. They don't appear to add a lot of value, to be honest, because if you've got a track that works, you're going to do better than someone who has a track that doesn't work. I mean, it really is that simple. And I know it's really disappointing because we've got so many fantastic, sophisticated techniques available to us. And so it's kind of, that all you really need to know is, can you get a response or not? Having said that, you know, today we were really talking about how this could be useful for trial design. A lot of our work is looking at how MEP status can be useful in clinical practice, because it helps clinical teams understand what to expect for that individual patient. And so at a couple of hospitals here in Auckland, it's now routine clinical practice to obtain MEP status on all appropriate stroke admissions. And the physiotherapists do that, and occupational therapists do that without any research input. So it's just part of their routine care. And having had the experience now of supporting the training and competency development of therapists to be able to use TMS in their clinical setting that way, I feel like it's enough. I feel like we don't need to be hitting them with, you know, paired pulse, intracortical measures. You know, just obtaining MEP status is about the right level of challenge for both the therapist doing the testing, but also the patients themselves, who, you know, they're not feeling great. They've only had a stroke about 3 or 4 days ago. And so they're okay with this kind of test, but often not putting their hand up for too much more.
And I guess that's an important point, isn't it? You know, having something that is actually doable both for the practitioners, but also, you know, for the patients themselves. It's important, and you know, if something as simple as an MEP is going to give you that, that's fantastic.
Yeah.
Great. All right. We have a question through here from Jessica Michael. So Jessica says, fantastic talk. I was just wondering if it matters at all where the stroke occurred in the brain and if this was controlled for in your sample.
That is such a good question, Jessica. Yeah, we had a pretty even distribution across both vascular territories and cortical versus subcortical versus brainstem. So it's important to note that everybody included in the sample that I sort of showed you very quickly did have upper limb weakness. So obviously, if they didn't have upper limb weakness, we didn't have a reason to be looking at them. So they did all have upper limb weakness, which means that they didn't have cerebellar stroke, but they did have some stroke lesion affecting those descending motor pathways. And it could be at the level of the cortex, subcortex, basal ganglia, and right down into the brainstem. And it didn't seem to make a lot of difference. If you can get a message through, you're in a better position than if you can't.
Great.